Hey guys, and welcome back to another video teaching session of, this time, bradycardia. Now I will be mostly speaking from a handout here, so feel free to refer to the handout that's also in the file folder where you found this video. But towards the end I will be looking at the Zoll, spoiler alert. So towards the end, yes, pay attention and I can show you some visuals with the Zoll's help. So we're going to talk about bradycardia today. So first of all, there's two types of bradycardia, symptomatic or asymptomatic. Asymptomatic bradycardia is often just a finding. The patient's, is a runner. They just run low bradycardic wise at night. Their heart rate might be 40s and 50s naturally. Or it's just a finding. I mean, we have folks all the time whose heart rates just end up being a little on the lower side. So as long as their blood pressure is fine and they aren't feeling anything, then, there you go. Now, unfortunately, if they are symptomatic, and when we talked about symptomatic, there's a couple things. Are they having chest pain? Are they hypotensive? Are they dizzy? Do they feel off? Anything like that, anything out of the ordinary, then yes, they are symptomatic and we'll need to treat that. Per the algorithm, there are three types of medications that we use for bradycardia. First up would be atropine, of course, and that is usually given in 0.5 milligrams IV push. Now, atropine can be found in the drug box on top of the code cart. 0.5 milligrams is half or 5 cc's of the vial that's in the code cart. That can be repeated a couple times up to a total dose of 3 milligrams, although you usually don't see it escalated that high. Once you get to 1 milligram or 1.5 milligrams, then it's time to move on usually. Speaking of moving on, the next recommended medication is dopamine. Now, dopamine is an infusion, it's not a push. And typically, dopamine is a vasopressor used for a cardiogenic shock or a weak heart or whatever you want to call it. In our case, we're looking for the chronotropic effect of dopamine. It has a secondary effect other than making the heart squeeze harder. It can augment or raise the heart rate as an effect, side effect, whatever you want to call it. That's what we're looking for. We're looking for a little bit more heart rate out of that heart, and dopamine can sometimes help with that. That is a bag that's supplied also in the code cart, or actually drug box, I'm sorry. And the infusion, you want to set it up in a pump. It's in the drug library, and that's in micrograms per kgs per minute. Dose is usually 2 to 20. I want to say, depending on how symptomatic the patient is with a bradycardia, you might see initial infusion dose of 2 mics per kg per minute, 5 mics per kg per minute, 10 mics per kg per minute. Now, in our unit, 10 is the cutoff, so they would be heading off to the ICU land if, in fact, they get to 10. All depends on how things are going, of course, with the patient, if it's an RRT code type situation. So, if dopamine doesn't work, sometimes, it's in the algorithm here, but you rarely see epinephrine used as a drip as well. Again, it's listed here as a drip, but maybe a little bit of a push depending on if it's a code, who's running the code. And again, epinephrine is going to be in your drug library in the pump. However, it might have to be switched to ICU mode for that. Dose for that is micrograms per minute. There's no kilogram involvement. And for bradycardia, it's recommended 2 to 10 mics per minute. And you would need to have that mixed up out of your drug box using the epi multidose vial and a saline bag. Now, if they are extremely symptomatic, it's recommended that you skip all those drugs and just really go to transcutaneous pacing. Now, also, that can be used as a tertiary or last-ditch effort to help the patient's heart rate. So for this, we're going to go to the Zoll in a minute here. Let's switch the camera around.